hidden on behalf of Medicine 5. Mr. R is a 41 years old farmer from Tiruvannamalai, came with presenting complaints of numbness, weakness of bilateral lower limbs since 10 days. So he developed weakness of the lower limbs, which was more on the right side than left side since 10 days, associated with numbness, gradual onset and progressively worsening. There was a history of slipping of chappals, tripping of toes. There was also a history of getting up from the squatting position. He felt limbs are stiff and hard. There was no involuntary movements. He was not able to feel his clothes below his thighs and not able to feel hot water sensation in left lower limb from just above the umbilicus till the foot. He also felt sensation of walking on cotton wool, and there was no band-like sensation, no root pain, neck pain, back pain, girdle-like sensation. There was history of difficulty in balancing himself on walking, and there was history of difficulty initiating and associated with initiation of urine and associated with poor stream while passing urine. There was no history of any bowel incontinence. However, there was no history of any blurring of vision, facial deviation, or nasal regurgitation. So, anyone wants to localize based on this finding? So, it is an insidious onset, progressively worsening weakness of the lower limbs, which is asymmetrical, right more than left, with associated loss of pain and temperature on left side, and on the right side, unable to feel his. There is also bladder involvement is also there, with a soft touch, that clothes not able to feel on both the thighs. So syndrome complex is its insidious onset, gradual progressive motor weakness involving bilateral lower limbs with sensory involvement as well as bladder symptoms, which is actually localized to cord. So now on examination, he was conscious, cooperative, pulse rate 80, vitals was stable, no pallor, cyanosis, clubbing, ictus, edema. CNS examination, memory, speech was normal, cranial nerves no deficit, bulk was normal. Tone, right lower limb was hypertonic, other limbs were normotonic. So, so on examination, sensory system, pain and temperature, it was lost T8 bilaterally and absent in the left side, T8 till foot. So T8 was the level, and fine and touch from the T6 level till below it was lost, and vibration in the right L1. So the highest level of the sensory was at the fine and touch level, the posterior column. Motor, it was a right weakness more than left weakness, with the highest level being the hip flexion, above which it is lost, below which it is lost. So the highest level of the motor was L2. So now the reflex level also, it was hyper reflexive of the knee and ankle. So the reflex level will be at L2 probably. So now other signs, cerebellar signs were absent, Romberg signs was positive, other systemic examination was normal. So the diagnosis will be demarcating the anatomical level, anatomical etiology, motor level at L2, sensory level at T6, reflex level at L2, and bladder involvement is there probably, which is supplied by L2 to S4. So it will be just it will be probably above L2. So the highest level of thing will be L6, T6. But there is patchy involvement, meaning like each level is different. L2 is involved, T6 is involved. So patient is likely to have a patchy cord involvement from T6 to L2 level. So the differentials considered. So first one, any infections like HIV, myelopathy, CNS TB with the patchy involvement, or a CNS TB with worsening edema involving other tracts as well, up and below. Immune-mediated longitudinal extensive transverse myelitis with infective etiology of TB, syphilis, tetanus, neuromyelitis optica, autoimmune disorders like Sjogren's, sarcoid, multiple sclerosis, and malignancies, metastasis, you can think of other paraneoplastic syndromes. So now, investigation-wise, CSF protein was elevated, and other than that, X-ray was normal, and other investigations of normal. So Fate score was coming to -5, so less than 5 suspicious of a TB, definitive TB, and Lancet's 15. So highly likely of a tuberculous CNS TB. So now we did an MRI which showed a ring enhancing lesion at the level of T5 and also in the tectum, the midbrain, with surrounding edema. So now I'll be talking about the localization of the cord as well as about the spinal TB, and I will come back to this patient. So when to suspect a spinal cord, first we have to determine that, then determine the level of lesion, then identify the pattern of spinal cord, then whether it's a compressive versus non-compressive, whether it's extramedullary versus intermedullary. So spinal cord lesion, you suspect whenever there is a definitive level of a sensory, there will be definitive level in of a segmental, there will be segmental signs. So there will be band of altered sensation, for below which there will be loss of pain and temperature on one side based on the pattern. And at the level of lesion, it will be LMN, and below the level of lesion will be UMN type of lesion. And presenting about different cord presentations. One is cervical cord. We can divide into upper cervical and mid and lower cervical. What differentiates is the weakness of the diaphragm, and patient will have respiratory distress because of the C2, C3, C4 nerve involved supplying to diaphragm. So upper cervical cord will be quadriplegia plus weakness of diaphragm, and they will have Georgia downbeating nystagmus and the cruciate hemiplegia, which is typical of a upper cervical cord. So cruciate hemiplegia is at the level of the middle-cervical junction. Usually the upper extremities cross first. The lower extremities cross little below that at the level of C1. So there is a point of interval where there is uncrossing of the lower extremities and crossing of the upper extremities. So lesion at that level, you will have ipsilateral upper extremity involvement and contralateral lower extremity involvement, which is instead of cruciate hemiplegia, which is a typical feature of upper cervical cord. However, if the lesion is at this crossing junction, then it's a cruciate paralysis. Then you will have a mid and lower cervical cord where there won't be involvement of diaphragm, and you can demarcate this based on the reflex levels, based on the absence of reflexes, C6, C7, and C8. Next, coming to thoracic cord. Thoracic cord, so as I said, you will have a definitive level of a segmental signs will be present, and at the level will be element type of lesion, and below will be UMN type, and there will be involvement of bladder and loss of superficial abdominal reflex, and the Beaver sign will be positive. T9 to T10 is involved. So if it is involved, the upper abdominal muscles will contract, and below the level of T10, the abdominal muscles will be weakened and the umbilicus will be shifted up, which is the Beaver sign. And lumbar cord is based on the same. So at the level of L2, it will be element lesion, below will be hyperreflexic. So this is a short table summarizing it. So now coming to the pattern of our patient. So our patient had a ipsilateral position sense lost and contralateral loss of pain and temperature. So it was localizing to the and the highest level of lesion was T6. So usually the fibers cross 1 to 2 levels up. So probably from T3 to T6 at the level of the left side, the hemicord lesion will be there. So as shown in the figure, the ipsilateral corticospinal tract and the position sense, the joint position sense, the posterior column and the contralateral spinothalamic tract will be involved. Below the sense of a segmental lesion at the level of, in our patient was T5. Spinal level was T6. However, we see that our patient didn't fit one cord level. It has a multiple cord level. The sensory was different, motor was different, and reflex was different. So we retook the history again, and we found out that he was not given steroids and he started on ATT. So which involves the, however, during the course of the illness, there was a improvement in his weakness and improvement in his sensation. So there was also a patchy involvement. So this explains that there's a patchy involvement of the cord and explains our examination and historical finding. So now I would also like to talk about the spinal TB. So the TB of the CNS accounts to 1% of all cases, and 50% involve the spine, out of which 8% is intramedullary, of which the most common is the thoracic spinal cord, which is 55%.
Osborn, what is your learning points?
Sir, one is localization of the cord, and second is the spinal TB I want to discuss.
What is the microbiological diagnosis here? Anything is there?
Sir,
that it is a TB?
Sir, only that scoring system was the one, and CSF proteins were elevated. That's the only thing. Apart from that, one case report I would like to discuss where it was a spinal TB, following which they gave steroids, and there was a worsening of the cord because of the increase in edema, and there was increase of the extramedullary lesion. So they started on ATT, and the lesion had reduced, and it was level from C3 to C7, almost similar to our patient. It was thoracic cord involvement.
Other workup for other differential diagnosis?
Sir, we didn't do, sir. We just.
So you consider empirical.
Yes, sir.
So other workup you didn't do.
No,
transverse myelitis, everything you mentioned, no?
Yes, sir.
Diagnosis.
And he also had one ATT from outside itself was started on. So.
We can move on to the next one. Thank you. Into the time, 10 minutes. 10 minutes in 10 minutes. You have to summarize, you have to learn to do that. Summarize, and we cannot present the entire case and do so much discussion. 6 cases we have to complete all 6.